Hello, hello. Thank you for watching. Today we're going to talk about JNC-8 guidelines for hypertension. So the major change that occurred between JNC-7 and JNC-8 is that elderly people are given a little bit of a break here. JNC-8 has recognized the fact that if we get patients' blood pressure too low, they will die, especially in the elderly, and for that, it is actually way more helpful to keep their blood pressure a little bit higher and not run that risk of hypotension. So, if you are over 60 and you have no kidney disease and you also have no diabetes, then you can have a blood pressure of 150/90, and that is fine. It does not need to be treated at that point. 150/90 is the goal. If you are under the age of 60, you're still at the 140/90 goal. If you have diabetes or chronic kidney disease, you're also going to be at the 140/90 goal. And so that's kind of the first step to JNC-8, is determining that goal. Then you look at your drug choices and you kind of determine what will be best for your patient. Now, beta blockers are really not talked about as much in JNC-8. That's because we recognize that that's really not necessary. It doesn't do too much for the hypertension in general. It's really better for patients with heart failure or post-MI. They should all be on beta blockers. But if you just have hypertension, you don't have heart failure, you haven't had an MI, then don't worry about it. The side effects are kind of not very, helpful to live in your life. And basically, beta blockers will make you feel like you have the flu almost every day. You feel pretty crappy. Also, impotence, meaning you will not be able to get an erection, and some cause bronchoconstriction, which can be really a challenge when you have patients with COPD and asthma. You don't want to put them on that if they're having an exacerbation, because it might be causing the exacerbation. So in the patients that are African American, we're going to want to start a calcium channel blocker. And that is because the research has found that in African American males, calcium channel blocker is number one choice. And research has also shown, especially in JNC-8, that a combination of drugs is going to be most helpful. You don't need to go all the way to the top of a drug's maximum dose. That just means you're going to have a lot of side effects. So go ahead and start the medication at a low dose, go up to a moderate, and then add your second one. Patients with a second drug are going to be under better control. Patients with two drugs are also going to be less likely to take them, but that's a whole nother story. So a really nice combination to add for an African American patient, even if they have diabetes, is going to be the calcium channel blocker with HTCZ, which is a diuretic. Those work better together than they do separately. The only time you wouldn't want to have a calcium channel blocker is if the patient is in heart failure. Then they are contraindicated. Also, if the patient has gout, you don't want them on the HTCZ. It's interesting because in general, you want to help the kidneys out if the patient has diabetes, but really you are going to help the patient more if you do the CCB if they are African American. Now, if they are not African American, you want to start an ACE or an ARB first. The ACEs and the ARBs have been shown to increase the patient's life, and so for that reason, we really want to use them first. Also, research has shown that in white males, ACEs are going to be the most helpful drug. That's because white males tend to be renin overproducers. Now, you could also add an HTCZ to this, and it will work really well also. All right, so So what you wanna do first is tell the patient, you get the one reading of the high blood pressure and you say, Mr. So-and-so, your blood pressure looks higher than usual, and what's really going to bring your blood pressure down is exercise and diet. So you want them taking in less than 2 grams of salt per day. That is very hard to accomplish. You might give them a goal of 2.3 or 2.4 grams. So that's going to be your first discussion point. Your second discussion point is the exercise. That's really going to help. Now take a look at this patient's medications. Have they been taking NSAIDs? Is the patient on oral contraceptives, corticosteroids, migraine medications? There's a whole host of medications that will potentially bring your blood pressure up. Think about, do they have any signs of hyperthyroidism? That's going to bring your blood pressure up. If it's a patient who's elderly, maybe like over 60, and this is the first time that they've had high blood pressure in their life, you can bet your bottom dollar that they're going to have an underlying condition, and this is secondary hypertension, not essential. So you might have a renal artery stenosis or something like that. That needs to be looked into. If they're under 20 and they're developing hypertension, you're thinking, probably not. So in that case, you want to look into other causes. And then the other type of person where you might think you want to look into other causes is somebody who is not Black and has very few risk factors and no family history. So somebody who's slender, doesn't have diabetes, generally healthy, all of a sudden high blood pressure. Then also somebody who maybe is refractory to treatment. So you tell them, decrease the salt, increase the exercise. You've looked into the secondary causes. They come in again. You get the second blood, probably 2 weeks later. You get the second blood pressure. It's high still. Now you can make the diagnosis. JNC-8 says 2 diagnoses on 2 separate occasions. In general, home blood pressures are not recommended. Why is this? Patients are taking them wrong. Also, patients get anxious because they're taking them. So, just do another triple check right now. Ask them, did you just drink caffeine? Is it possible that you have white coat syndrome? Have you had it taken other places and it's fine? Yeah, so have they just exercised? Whatever it is. But you really at that point, unless you find another cause, have a diagnosis of hypertension. So you want to pick one of the drugs that we just talked about. An ACE, an ARB, a calcium channel blocker, or a diuretic. Have them come in 2 weeks later. Are there any side effects? And then take their blood pressure. If they're not at goal, you want to increase it. Bring them in 2 weeks later. Take their blood pressure. Are they at goal? And now you have a higher chance of side effects. Ask them about that. If they are still not at goal, which we've discussed is for elderly with no chronic kidney disease and no hypertension, is going to be 140/90, and for everybody else, 150/90, and for everybody else, 140/90. So if they're still not at goal, you want to add a second medication, and just keep doing that until you get their blood pressure under control. All right, hope that helps.